discussing today's topics from an African American perspective. This is Another View.
Hello, everyone, and welcome to Another View. I'm Barbara Hamlee. Hope you're enjoying this beautiful sunny afternoon, because I understand the weekend's going to be a little bit wet, but that's okay. We're all here together. So in 1966, Dr. Martin Luther King said, quote, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." In 2013, the Centers for Disease Control and Prevention released its CDC Health Disparities and Inequalities report. In it, they examine social, environmental, and behavioral risk factors, along with access to health care, in determining if we've made progress in eliminating health disparities in this country. Sadly, the gulf between black and white health care in this country continues to widen. My co-host for Another View on Health, Dr. Keith Newby, is here today. Hey, Keith, how are you doing?
All right, and yourself?
Good, I'm doing great.
Always a pleasure.
Always a pleasure. Along with journalist, author, and Another View pundit, Wil LaVeist. Hi, Will. How are you?
It's a pleasure. Twice in 1 month.
I'm telling you, that's exciting stuff. Absolutely. And along with Dr. Thomas LaVeist, the William C.and Nancy F. Richardson Professor in Health Policy and Director of the Hopkins Center for Health Disparities Solutions at the Johns Hopkins Bloomberg School of Public Health. Although, Dr. LaVeist, I understand that's been a change in the last couple of months.
Yes, I'm a recent retiree from Johns Hopkins, and I'm now over at George Washington University School of Public Health.
Oh, okay. There you go. So I'm curious, Dr. LaVeist, first I'll start with you. How does a person who is a part of public health and public health disparities become a filmmaker?
Well, I've been doing this work for several decades now, and after 25 years of writing articles and when I published my 100th article, the disparity in life expectancy between black and white Americans was about the same as it was when I published my first article. But it occurred to me that, I think it was Einstein that said the definition of insanity is doing the same thing, expecting a different outcome. And determined that I would be an insane person if I just continued to publish articles and do studies on this topic and not try to do something more. So the idea of making the film was to take all of the knowledge that we have developed, not just me, but researchers all over this country have gleaned about why African Americans live sicker and die younger, all that information that's locked away in the library, medical library, take it out of the library and put it into a format where people can understand it.
Okay. Did you have a question you wanted to ask before we listen?
No,
I'm
good.
Okay, we're going to listen to an excerpt from The Skin You're In, and then we'll talk about it some more on the other side.
In the United States of America, in the year 2013, African Americans live sicker and die younger than any other ethnic group in the nation. Why would it be that your skin color would determine whether or not you get hypertension, diabetes, heart disease, cancer, stroke, how long you'd live?
We as African Americans go to funerals like we go to the supermarket. Death is a continuous event in our communities. For a young black man to say, "I'll be lucky if I live past 25," that's a common phrase. My father and my husband, both of them passed away at the age of 40, passing away at such a young age from cardiovascular-related illnesses. No way that this is coincidental. We accept sugar runs in our family, diabetes runs in our family, high blood pressure runs in our family, obesity runs in our family. Knowing that is one thing. Doing something about that to reverse that generational trend is something completely different.
There's no pork in the collard greens, no pork in the string beans, no pork in the cake. But we do have pigtails in South.
When we look at the consumption of comfort foods, or as we call it, soul food, this is a way of coping with stress.
Food is a constant in our culture, and that's how we express love, happiness, sadness, put food on the table.
Being a woman and being black, there was just so little room for error. When I would walk into corporate America, people were instantly wondering if I was just there to fulfill a quota. You don't want to do drugs, and you don't want to drink, and you don't want to smoke, but you can eat a brownie. It's quick, and it's easy, and it temporarily makes you feel better.
we're weathering because of that stress that we live under that's associated with racism and discrimination and the behaviors that we engage in to help us cope.
The women in my family have died from obesity-related disorders.
You don't want to go to a family gathering and just imagine people who are going to die because their body size.
It's scary. I had sleep apnea at 23. I had high blood pressure. I was pre-diabetic. Poor quality food. It's a part of our lifestyle because it's what we have the easiest access to. That's what we saw our parents eat. That's what we see our friends eat. That's what's in our neighborhood.
When it comes to racial disparities in health, your zip code has a lot more to do with your health than your genetic code. You drive through any black community in this country and you'll see check cashing places, liquor stores. What you won't see are supermarkets that sell fresh fruits and vegetables.
African Americans are 79% more likely to live in neighborhoods that pose an environmental health threat than whites, where there are facilities that release pollution, where there's industrial sites that have been abandoned.
Communities that don't have access to open space and parks where people can exercise. All sorts of environmental hazards, including crime.
We have been dying because we can't get the normal help.
We have an enormous amount of resilience and endurance to just contend with so much.
I got trust. Yeah, proud of me. Oh.
Every day I'm amazed. I say, wow, wow.
In this film, we'll meet people who have made change in their personal lives, who have transformed their communities, who have made changes through the policy process. Just as there's proof all around us that we have this cycle of death, there's also proof all around us that we can make change, that we can break that cycle.
No community should be poisoned. The fights that we wage, they are not sprints. These are marathons.
We can choose to live as opposed to accepting a fate of death as if there is nothing that we can do about it.
Wow, powerful sound from the documentary The Skin You're In. Will, where is the documentary at this point? What stage are you all in?
I would say that what do you think, Tom, about 80% done in terms of filming?
Yeah, we're about 80% through the filming, and then, of course, there's post-production where we edit it and bring it all together. So, I don't know, we're probably a little more than halfway done.
Okay. And there are some others that are working on the film with you. Isn't that correct, Will?
Yeah, I mean, Tom has a lot of the, because it really was his brainchild that brought it together. And, one of the things is that over the years, me being a journalist, my brother had always been talking to me about how can he, as he was alluding to earlier, get this information into the public domain. I would help him even with his presentations and how he would need to speak, to an audience, because as we know, and Dr. Newby might agree that these doctors can be very challenged when it comes to speaking normal English to people, and also the same is the case, with researchers as well, because they're so used to talking to their own discourse community. And so Tom got together and started getting a team of people who know how to make films together, and it brought me on really as that trusted journalist that he knows about, as well as my focus being on the web component, because actually as I work on my dissertation, it's really about developing a rhetoric for communicating health and technical information to primarily African American audience. Mm-hmm. And so what we'll be doing on the website is really producing a website that takes this documentary film and other information and accomplishes the same goal. How do you communicate this to a more general audience so the way they can be empowered, understand it, make better life choices?
So, Tom, how is the film being received at this point from what you're showing people now?
Right. Yeah, I think it's been extremely well received. People respond to it. It's a very emotional topic. People do come to tears because everyone's got that story. Everyone knows some 32-year-old who had a stroke or a 28-year-old with a heart attack And it happens so frequently in our community that sometimes we think that that's normative. You know, we think it's normal. You're supposed to become hypertensive, and then from there, it's the natural progression to become diabetic, and then the next natural progression is to start to receive amputations. And there is nothing normal or natural about any of that. But everyone's got that story or that family member or friend who's lived through that progression. And so people respond to it because it's a topic that everyone can relate to.
So for those who are sitting out there in the audience now and they're thinking to themselves, yeah, but they brought it on themselves. I mean, you can do something about this. What's your response to that, Tom? Is it something that or I guess the better way to ask the question is, how much of a personal responsibility do we have in this disparity in our healthcare?
Yeah, that's what I call the most common dodge that people put out there, that it's really up to you. There's no reason why you're eating this unhealthy diet. There's no reason why. But you know what? Most of the health disparities problem is not about individual behavior. It's about the communities that we live in. African Americans are more likely in this country to live in communities that are unhealthy, communities with environmental hazards that we don't even know exist in our neighborhoods, communities that don't have access to healthy foods. Even if we did know what were healthy foods, and most of us who think we know what's healthy don't really know what's healthy, a healthy diet. But even if you did know, many of us will live in communities where those foods are not even available to us. So the hazards that affect our health are not only about health behavior. Of course, health behavior is a part of it. You know, you need to be engaging in health behaviors that are helpful. But even there, the behaviors are often the response to the environmental and social stresses that we live under. So the eating, so we eat as a community high sodium diet, which was protective years ago when we lived under the challenges of slavery and Jim Crow. But now we live in a sodium-rich environment, and in this sodium-rich environment, you don't have to add any sodium to your food in order for your body to get all the sodium it needs. Most of us don't really understand that, don't understand that the canned vegetables have sodium in it. We think we're eating vegetables, and that's healthy. And so I think it's not just about individuals making decisions, but it's also about environments and environments that place us in a position where we're making choices, we're selecting from a set of bad choices.
Will, you want to add to that?
Right. So, for example, if you're disproportionately poor, and let's say that you're having to rush and maybe do 2 or 3 jobs, and it doesn't afford you the opportunity to eat more easily, stay home, and be able to cook a more healthier meal for your children. So you begin to do what is the quickest thing. Let me stop and grab some fast food. Let me stop and do this. Let me stop and do that. And then what happens is these foods, like a lot of sweets and different things, are difficult for you to change that habit. You like the way that feels. You heard from the promo that we take a lot of these foods because they make us feel good. They release endorphins. It's human nature to want to feel good. You don't want to walk around feeling bad all day. So when those kinds of things happen, it becomes hard to move away from those foods because of the effect of making you feel good that it has on you in light of your condition that you're living under. But in reality, in long term, it's really just being destructive to your health. Now, the problem becomes, when it comes to personal responsibility and why we're doing this film, is to give people the information, show them how individuals are actually on the ground and doing things differently and making different choices to empower them to now make and see how they can make positive life choices. And if they don't, that does become, at that point, a personal responsibility. If you've been given an alternative way, we've shown you how you can do it within your budget, and you still choose to make a destructive decision, well, that's a personal responsibility.
That's what you see sometimes in your practice, isn't it, Keith?
Yeah, you see that. I mean, that's pretty common nature. With the challenges that I think I have as a cardiologist and as a physician itself is trying to change the mentality that people have. And I've heard the same thing. I have other patients who are of a different socioeconomic background who may make the comment that say, well, folks bring this stuff on themselves and what have you. But what I try to convey back is, listen, we don't know a person's background. If you've been living a certain way all your life, if this is what you know to be true, just like you talk about the mentality of people going to jail. I talked to a teacher who told me that she's in middle school. It was sad to see that it was a mostly African-American school, and the kids at 5, 6, and 7 years old, they aspire to go to jail when they get older because their uncles, their fathers, their brothers are all in jail, and they look at it as a glorified lifestyle, so they just don't understand that's not normal. It's just like Dr. LaVeist mentioned earlier, that this is, people sometimes they have nowhere to really to look for because this is all they've known. So if this is all you've known, and then somebody comes and tell you something different, it's hard to kind of change your culture to say, okay, let me go a different way. Plus, to be honest with you, it costs more to live healthy. A way that the current situation in America is set up, if I go and buy some well-cooked meal, it may cost me $15 versus I can go to McDonald's and get a $1 meal. And you look at and you'll be full. So
full of gas, full of air.
Well, when you look at just the basic, I have to live,
right?
And if you're on this fixed income, and somebody's telling you, okay, you need to eat this kind of stuff, he said, but it costs 10 times as much. I can't afford to do that. It's tough for somebody that really doesn't. And they may understand, but not necessarily the impact it has. We live for today. We don't live for tomorrow.
And that's why the film aims to show people how you might be able to make a healthier choice in the current situation that you are, and showing how people all over the country are trying to make a difference and doing different things. And what Tom said about that being a dodge, when people start saying, oh, it's personal responsibility, he's right on, because you got to look at the people who make those statements. A lot of times they're making those statements because it makes them feel better that they don't have to be responsible to maybe do something or acknowledge that their condition is the way that it is because they've been privileged in certain ways and others have not.
And to that point, there was a study done by the Robert Wood Johnson Foundation. The quote exactly from them is, "Your health depends on who you are," according to a 2014 report from that foundation. And they talked about, for example, in low-income neighborhoods, patients with diabetes 10 times more likely to undergo limb amputations as opposed to those who are more affluent. For breast cancer for women, the less invasive techniques are used less on certain groups of people, particularly African-American women, than they are on white women. So within the system itself, too, Tom, there are some disparities that cause some of this disconnect, isn't there?
Absolutely. So the disparities are in part, I don't want to give the impression that I don't think that health behavior is part of this. Clearly, it is a part of it, but I think it's not the biggest part. There are systemic issues. We do know that African Americans, there's a very large research literature that shows that African Americans are less likely to receive high quality and intensive health services when they are indicated compared to non-African Americans. I would also say that, as this conversation rolls out, it's very important to point out that high-income, highly educated African Americans have shorter life expectancy and higher mortality rate and higher rates of virtually every disease compared to whites who have similar levels of education and income. So this is not just a poor issue. This is not only an issue of poor blacks. Affluent African Americans, much higher rate of obesity compared to whites of similar economic status. And there's a study that we recently did that we have published that shows that African Americans with incomes over $175,000 a year have a higher rate of hypertension than lower income African Americans. So this is not just an issue for poor blacks. This is an issue for black people across the board.
Just out of curiosity, if I could ask, in that study, how did it, when you talk about the same socioeconomic background, was there any information that alluded to the choices made? Was that a choice based on opportunity, meaning Were these people given an opportunity to say they could do one thing or the other, or was it that they, it was just their choice, or were they just not given the opportunity at all? Meaning, say, like example, if you have somebody that needed bypass surgery versus medical treatment, and were these, if you looked at the two groups, white and black, were they both given an opportunity for bypass and they turned one down, or was some just not given the opportunity at all?
Yeah, I actually did a study on that exact question that you just asked. And what we showed in that study was that there was a big disparity between blacks and whites in who got a procedure called coronary angiography, which is basically a diagnostic procedure for heart disease. It's sort of to sum it up. Mm-hmm. And we found that in this study, we only looked at patients that were insured and who had insurance that would have covered the procedure. So we took out everyone that didn't have insurance. And among people that had insurance that would have covered the procedure, about 80% of white patients that should have got it did get it, but only about 58% of black patients that should have got a referral were referred. So there is a disparity here, even among people that had the insurance, that was seen at a hospital that could have provided the procedure. But then we looked at, among those that got a referral to a cardiologist, what we found was that the disparity, or race disparity, in who wound up getting the procedure dramatically reduced if they got to see a cardiologist. So the disparity that was happening was who got referred to a cardiologist. And we found that the black patients, and I want to stress again, I'm talking about patients that had insurance and that had the ability to pay for the procedure and needed the procedure. The black patients were dramatically less likely to get referred to see a cardiologist. But once they saw the cardiologist, the disparity was still there between black and white patients, but it was only a small disparity.
Okay. 440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. If you're just joining us, we're talking about health disparities in the African American community with filmmakers Wil and Thomas LaVeist. Their new documentary is called The Skin You're In. And my co-host, Dr. Keith Newby, is also here with me. 440-2665 or 1-800-940-2240. So I want to ask the question about training. Well, first, let me ask another question first. Well, if you remember a month ago in the roundtable, we talked about the fact that there was an article that came out that said that blacks were given less pain medication when they would go see in the emergency room, as an example, compared to their white counterparts. Where is the training, and I'm looking to the two docs for this information, that you receive about different ethnicities? And I guess I'm trying to get to the root of where does this idea come from that African Americans need less of in terms of the care?
I don't think it's so much that you need less of. I think it's people's perception of those individuals, when they come to the emergency room, and just hearing, when you're in the medical world, you hear things, and some things you comment on back on, some things you don't. But what happens is you think of how the media has painted a picture of a lot of African Americans to say, like, we're, drug dealers, we're pimps, we're hookers, we use drugs, we sell drugs, we do all this. And if you see that as, and I know I may get beat about mentioning Cosby on the air, but one of the things this show represented at the time it was out was a different outlay and outlook on the African American family, which I really applauded. And people would say things like, "That's unrealistic," and I'm looking at them like, my family came up not far away from things like that. My mom was a professional, my father was a professional. I said, "What do you mean?" But it's just the perception of people. So when you have somebody come to the emergency room and they're saying they're in pain and they're asking for certain types of medications, sometimes people's perception is they're asking for a specific reason, not necessarily because they're in pain, but because they want to do something else with those meds. And I hear it all the time. So I mean, I can't, and I'm just telling, this is just me sharing with you what I deal with on a day-to-day basis of hearing things and how people perceive African Americans in certain situations. Now, and again, that's not just African Americans. Sometimes it does. It's the basic socioeconomic look. If you have somebody who may look like coming with a suit and tie, and one thing they may get treated one way versus somebody who may not be dressed quite like that. You see some of that as well. It's kind of variable.
So you're saying the media is influencing you
well,
on making that
it's
decision.
not me personally. I'm just saying this
in
general.
That's
You will see, because one of the things is like was a Hollywood Shuffle movie when they were talking about how some movie producers may say that you can only get certain roles. And a lot of people that you'd be surprised. I mean, the American population, we can be a little interesting in how we perceive the world and how we view things based on what we see on TV. I mean, when you talk about good journalism, like what you do versus people that just have a certain outlay, how they put people on the public's eye, they can really affect how we see things. I mean, I don't feel that way, but a lot of people do.
I think the media is part of the problem, because the media comes from the society, represents the society that we that we live in. But I think that also what's going on as part of the problem is what happens in medical schools and what happens in people's practices, and how people bring their background and their biases into a medical situation. That's something that doctors ought not to do. And it's something that doctors somehow have an ability to back away from. For example, when they go overseas and they do work and they're able to adjust to the cultural context overseas and give people the things that they need. And they ought to be able to do the same in this context too.
Well, I would argue that physicians are adjusting to the cultural context of America, and that when you hear about that study, believing that African Americans don't feel pain, it's really to me those are the attitudes of Americans, and it's like when a police officer shoots an unarmed African American man, he's not necessarily being a bad cop. He's maybe just being a good American, someone who's steeped in American culture, who has this set of beliefs and attitudes about African Americans. And when you see blacks do it, look, African Americans are Americans too. So these values, these attitudes that devalue black life, are attitudes that permeate the society. Medical professionals are members of the society also.
Mm-hmm. Let's go to Matt in Virginia Beach. Hi, Matt. You're on the air.
Hi. A couple of things. First, thinking that one group or another feels less pain is a direct and expected consequence of dehumanizing one group or another. But what I actually wanted to call about was this notion of food and nutrition and the inability or difficulty of getting good quality food in some places at non-astronomical prices. And I've been thinking about this for a while, this notion of food deserts, and then an approach might be some organization called Oasis, which exists only in my mind, where Oasis is a place that it started out as a notion of a grocery, but as well by partnering with cities to get space and a grocery distributor or chain to get food not for free, but at the same prices that large grocery stores pay, and offering some very basic health services like diabetes screening and immunizations and so forth, and perhaps some educational classes in nutrition and food preparation. That this could actually be quite helpful in many places. And then by coincidence, last night on the NewsHour, there was a program, a segment on an organization called Daily Table. And they've got a website, dailytable.com, which is open to a grocery. It was founded by former head of Trader Joe's. So obviously, he's a fellow who knows quite a bit about food distribution and so forth. And what they're offering is high-quality food at excellent prices by very careful purchasing. And one of the points that they make is that there's a whole completely different dynamic when people are actually buying food, even at very good prices, but in a retail store, versus handouts and soup. Nothing wrong with soup kitchens; they're important. But so I'm going to contact, and what he's offering up there is excellent food and some nutritional education. But by coincidence or not coincidence, he's also partnering with some hospitals up there, I guess, for nutritional guidance and so forth. And so I'm actually going to contact them about perhaps getting involved or expanding the idea to include something beyond food, which is vitally important, but also child care for the people that work there, and
okay,
so on.
Matt, thanks so much for sharing that with us. We appreciate that. And Matt brings up a good point there. Well, tell us some of the other things that you found in the documentary, in your filming, that communities are doing to try to make a difference.
Well, that's exactly the point, is that we profile different individuals who are doing things about food deserts. We profile, there's a pastor down in, I believe it's down in Memphis, Tom, who...
Yeah, Mississippi.
In Mississippi, who got his church to realize that, look, there's, churches are black churches are, notorious for, Sunday dinners and big meals and so forth. But he got his church to begin to understand that there's different ways in which we need to cook these meals that are going to be that should be healthier. And so there's a lot of different profiles like that of people who are making a difference. Because when you think about, for example, poor nutrition and how that affects a child who is now in a school trying to learn. If you are not healthy, if you're hungry, if you're not getting the nutrients that you need for your brain to be working at the optimum level, it's going to impact the academic success. Then that just snowballs. It snowballs, exactly. And before you know it, you have a child who's ended up in prison who really, a lot of that could have been headed off if they had better nutrition when they were younger.
Let's see. Dr. Harold Marino joins us from Newport News. Hi, Dr. Harold Marino. How are you?
Hi, Barbara, Keith, and your guest speakers.
How you doing?
I was trying to address the issue that you were just talking about, the opioid and African Americans with the myth of needing less pain. There's an excellent, I've been doing a lot of reading on this, and the myth actually stems from physicians back in the antebellum era in the United States. And they created this myth that blacks did not require as much pain to justify the experimental surgeries that were performed in the antebellum era to perfect surgical techniques. Now, at first I thought this was strange until April 2016, UVA did a study to see if these myths actually had an effect, and they surveyed their medical students and residents, and those myths actually were created stemming all the way back to the antebellum era. As a matter of fact, if you look at the data, most African Americans are underprescribed for pain. And if you look at further data, you'll also see that the opioid use has not significantly changed in the last 15 years. However, if you look at that myth that whites need more pain medication, it may justify in a bad economy why we're having so many opioid and heroin addictions and deaths that are occurring. Of course, it's now being addressed. You hear politicians now talking about we're going to do something about it. Well, nothing was done when it was an African-American problem. But
Dr. Marino, you must have been reading my mind, because that was going to be my next question about the disparity in terms of how heroin use, and we see how it's being covered now and the changes that are being made when that was something that's been going on in our community for decades.
Right, and this is another healthcare problem that I'm just going to throw at you with the things that occurred during the antebellum era, surgical procedures that were performed without anesthesia. Slaves had no choice. At the creation of medical schools, they needed cadavers. Look at the high numbers of African Americans that were the cadavers. If you look at University of Georgia School of Medicine, 10,000 desiccated bodies that were found in the basement. They were ours. And then you have this oral history that says, I can remember people saying, don't go to Hopkins. You might not come back. Or some of the other facilities that were there. So this unconscious bias, in my opinion, has deep roots and deep effect on our patients. So when we look at patients that were treated prisoners, when you look at the numbers of the Tuskegee Airmen, there are numbers of cases that will show this. Those beliefs stick with our patients.
Okay, let me
and
let.
there's a big distrust.
Yeah,
So
let me
I'll
let.
stop. I know.
That's okay. Let me let our guests respond to you though, and thanks so much for calling. We appreciate that.
And I think
go ahead, Will.
He raises an excellent point, but I think, and this may make some people uncomfortable, is that, as my brother alluded to earlier, being in this society is going to have an effect on you, black or white. So the sad part of the commentary there is that there are also a lot of black doctors who are perpetuating these stereotypes as well. If you hear what he said about the study, and that when they were referred to cardiologists, the disparity declined. So a lot of them were not getting the referrals. So if you want to make the assumption that a lot of these black patients were seeing black doctors, that would also say something about the black doctors buying into a lot of these stereotypes. And so we see that in all kinds of aspects, in all industries. Barbara, you and I in journalism, we've been in newsrooms where we've seen our fellow African-American colleagues who we would think are there to advance the ball for black people, and they don't. We see that in our judicial system. You have judges and lawyers in places where they make concerted decisions that heap more destruction upon black families, and they have the opportunity to make different choices. So this is part of what the film is also talking about early, as well, is that this is not just about poor black people. This is about being educated and empowered, and all of us working our way through these stereotypes and not reinforcing them because it's destroying our people.
Keith?
I 100% agree with what Brother LaVeist is saying. This has been an ongoing problem that I think we've had for years, and the unfortunate reality is that there are some, it's almost like crabs in a barrel kind of a mentality where we'll pull each other down instead of uplifting each other, and I see that in day-to-day living.
Right here in this community.
Yeah, I see it all the time. You and I could have some conversations about that. But, I think that's when it takes people, such as myself and others who are in the community to really promote those types of abilities so that we're not allowing the continued disparity to take place. I'm a firm believer. When one thing I can honestly say for me personally, I treat everybody the same. I don't see it, but when I see my people that will turn down something, sometimes I'll say, I think you do need a heart catheterization. Then I got to go through the debates about why they don't want to do it. And I said, listen, I'm just trying to keep you alive right now. Right. I said, let's debate the point later. I said, but I'm trying to give you what I really feel is in your best interest, and I will give the reasons there. Sometimes, unfortunately, people are not going to give that extra bit. They'll sit there and say, okay, this is what you need. I don't want that, fine.
Right.
This is what you move on, but our job as physicians is to go that extra mile, to take that extra step, because we're trying to do what we truly believe in. And if we believe in what we're saying, I took my Hippocratic oath very seriously when I raised my hand to that, and I said I would do everything I could. Unfortunately, what I'm finding is, in medical school, they can't teach you personality. They really can't. They can't teach you compassion. They try, but that has to be formulated somewhere else, and then, you can improve upon it. But I have found, though, that when you're in medical school, they teach you the bread and butter, and they will mention aspects of compassion, but that has to be something intrinsically in you.
Well, that's exactly why what is driving my brother with this film, The Skin You're In. And he's humble. He's not going to say a lot of this, but Tom, and all of what he's accomplished at Hopkins and all this, Tom is from the hood. You grew up in Brownsville, public housing. Tom almost died as a child from asthma because of the environment that we lived in, and thank God we had kind of parents, and we were able to get him the kind of care that he needed. This has happened before I was born. Mm-hmm. And this is the kind of thing that has driven him in being tired and confronted with colleagues who don't have that same kind of passion or don't have the same desires or more interested in just building their own careers rather than really moving the needle for our people and people in general. Mm-hmm. And what really needs to happen is, regardless of your skin color, all doctors need to be culturally competent. It's just like us, Barbara, as journalists.
have to be.
You went into white neighborhoods and covered the neighborhood.
Absolutely.
The truth. We give a pass to white doctors, white journalists, white, you can go down the line, who say, well, that's not my cultural context, so I'm not as interested. No, if your calling is to serve people, it's got to be all people.
Absolutely.
Yeah,
Dr. LaVeist, let me ask you about this whole thing about the heroin usage and what we see happening in Congress and all the discussion now about it being the addiction being a disease and so forth. Talk about the disparity you see now compared to what was happening in our community in terms of heroin.
Well, I don't think this. I think it's pretty obvious what happens when the illicit drug problem was primarily viewed as a black problem. It was viewed then as a criminal justice issue, and the police was used to address the problem. Now that we're seeing it happening in white communities, rural communities, small towns, and middle class white families, it's viewed as a public health problem. And we're deploying public health resources and social work resources instead of criminal justice. So I think, this is why it goes back to what I was saying previously, that it's not necessarily that the physician that doesn't treat for pain is being a bad doctor. What they're being is a normal American. They have a certain value for black life, and that lack of value, seeps into the work that we do, no matter what your profession is, whether you're a doctor or a journalist or a police officer.
We had a caller on the line. Her name was Frida, and unfortunately she hung up. I think she was listening to our conversation, hopefully. But she wanted to know about family communication and how critical is family communication as we look at the disparities and trying to make sure that we keep our own families healthy.
100%.
Tom,
okay,
let's start with Tom first.
Yeah.
Go ahead.
Absolutely vital. We often hear about, and this was in the trailer, sugar runs in our family, diabetes runs in our family, things like that. And the next time someone says that to you, ask them, what exactly do you mean by that? Do you believe that there's some gene in your family that's producing diabetes?
They do.
It's producing hypertension?
They do.
Well, there's the problem. So we know that these diseases are not single gene diseases. They have these diseases have complex causes, but mostly it's about behavior and environmental exposures, not about genes. We do know that much.
100%
right?
with you.
So it does run in your family, but what runs in your family is that diet, the way of managing stress, the way that you live in your life. That's what runs in your family, and that's why everyone in your family is diabetic. It's not because there's some gene that's producing it. So I think we need to start looking at how we communicate about these things. The way we deal with death. We go to funerals. We go to a funeral of a 22-year-old who died of a heart attack. This is a true story. 22-year-old heart attack. Now, just in case you didn't know that, that's not supposed to happen. That's not normal. You don't die in the early 20s of a heart attack. That's atypical. It should be. But the conversation is about how good he looked in the funeral. Oh, they sent him off good. This is the conversation. The conversation isn't what was going on in his life, what was going on in our family, what was going on in the way that he's living that would produce something like this, so that we can start to educate ourselves about what are the things that we're doing that's causing us to die at young ages of conditions that are typically viewed as being diseases of the old.
Hey, Tom, can you share the story about the sister down in Nashville that has her whole family involved in CPR, and also her husband is a cook? Can you share some about her as an example of the solution of a family that's making a difference?
Yeah. So Catherine Brown, who lives in Nashville, she teaches people CPR. CPR is, African Americans and Latino communities. There's been a number of studies that show this, that when someone is unconscious in a black community or Latino community, we are less likely to have someone around that knows what to do, know how to administer CPR correctly. And what she does, she's taken it upon herself to personally go out into the neighborhood and teach people CPR. If she was in the room with you right now, she would not let you leave that room without knowing CPR. I know this because she did it to me.
Yeah, she
At a
did
big
it.
conference
We
with
were
a
with
lot
her.
of-
We went into what amounts to being a biker bar, and she was
Really?
in there
And she
doing
did
CPR.
CPR?
Yeah, she just
Wow.
rolled up in there. Said, "Go ahead, Tom. Sorry."
She went up in this biker bar in North Nashville, and we just followed her with the cameras. We didn't know what else to do. We just followed her. But she was fearless. And she went in there and said, "You're going to learn CPR." And she's teaching people on pool tables how to do CPR. We went into the housing project and was teaching kids right there in the middle of just there in the project how to do CPR. It's not a difficult thing to know how to do. I would point out also that Michael Jackson died partly because the cardiologist that was there with him didn't know how to do CPR properly. You can't do CPR with someone laying in a bed. You know, when I heard that, it was like, oh my God, he was laying in a bed and he didn't get him out of the bed and get him on the floor. So, you know, CPR is a very easy thing to learn. Anyone can learn to do it. You do not need any kind of medical training to be able to do CPR, and everyone should know how to do it. And she has taken it upon herself to teach as many of our people as she possibly can.
Keith, you got
I was
something
just going
to
to say, I wish you didn't mention that cardiologist part of that statement, because I was thinking the same thing when he passed away, and I heard about it. I was like, dude, man, I thought you knew a little bit better than that. But anyway, yeah, that's...
Well, you know, the 10 leading causes of death, according to, this is the University of Cincinnati, and the first 3 were the same for both African Americans and whites, which was heart disease, cancer, and stroke. Okay, so those first 3 stay the same. But then there is a divergence. So number 4 for African Americans is diabetes. Diabetes doesn't show up until number 6 on the list for top 10 of things that kill white people. Alzheimer's shows up on the white list, does not show up at all on the African American list. But homicide is number 6 on the African American list, and that does not show up anywhere else. I mean, that is an environmental factor that we've got to also take into consideration. Isn't that right, Tom?
Absolutely. I mean, homicide is part of it. So in the issue with homicide, it's not just the death that occurs because a person is killed, but there's also the consequences to the community, to the neighborhood. So if you live in the neighborhood and you see that people are being killed around you, what does that do for your own sense of personal safety? Mm-hmm. And that stress, that external stress, it's not you, it's not your family necessarily, but you know that you're at risk. These are the stressors that lead to us being more likely to smoke, more likely to eat unhealthy diets, more likely to be fatalistic and believe that we won't live to be 25 because that's very real to you. So homicide's consequence goes far beyond just the person.
I haven't thought about it that way. Go ahead, Keith.
Well, one of the things that I've found is the biggest challenge if you're treating African Americans in terms of the things like heart disease and hypertension and diabetes is the lack of symptoms that people have. You know, one of the biggest challenges I've had is getting people to take the medicine. And part of the issue is if they have an infection, like say a pneumonia or some ulcer in the leg and it's painful, and they know they take this antibiotic, and most people will take it. They take it up to the point of time they feel better, then they stop, even though it may be 10 days. The problem when you talk about hypertension or diabetes is challenges I run into is people, because they don't typically feel bad with those types of disease processes, they don't understand the reason why they should have to take this medicine. They say, well, I felt fine until I started doing it. I'm like, no, you didn't. You just think you did. So that's the real challenge I run into. And people walk in my office 220 over 140 blood pressure, and they just like saying, I feel great. And I'm looking at their heart, and the EKG is just totally messed up. Their ultrasounds, where you get an ultrasound, the heart's
so
like
they don't even know that they're feeling
they
bad.
They don't understand
that's
it.
Their norm.
And think about it, the most of the time they may ultimately feel bad, but it's such a gradual progression of it that you don't really understand that you feel bad because of this disease process. It's like they say if you take a frog and you put him in cold water, and you put him on a stove and you heat it up slowly, he'll sit there till he boils to death. But if you take hot water, throw him in, he's going to jump out. Mm-hmm. A lot of these disease processes, because they're slow to progress, that people don't necessarily feel bad. They don't think they feel bad from the disease process. So you're trying to convince people, I need you to do this or change this lifestyle part or or change that. And most people don't even really, to be honest with you, you could get away with hypertension and diabetes in a lot of people without taking medicines at all, but they won't do what you need them to do to get
in
there.
terms of changing
Change
their
the
diet,
lifestyle,
losing
the
the weight,
stress release,
and so forth.
weight loss, dietary changes. If you look at most data, it says if you lose a certain amount of weight, your blood pressures will normalize in a lot of people. Not everybody, but a lot of people will. Diabetes will go away, or at least get to the point where you don't need medicine. But you got to follow the rules. People want to live by their own rules, wondering why it doesn't work. I'm like, you can't go to McDonald's, you can't go to Wendy's, you can't go to Dairy Queen every day and get something there and then say, I'm fine and I'll be okay.
And Barbara, that's exactly what we're trying to do with the film, The Skin You're In, is to show people that there's an alternative.
So how can people find the trailer? Where do they go? What website?
Well, the website is tsyi.org or theskinyou'rein.org.
Okay.
Tom, you want to add anything to that?
Yeah, that would be the way to get to the trailer, and at least you can sign up there to follow us, get updates. You can also find us on Facebook, and please do go onto the page, and you can get updates and follow our progress as we continue to film. To make the film.
We wish you both the very best with this film, and thank you so much for joining us. That was Dr. Thomas LaVeist, Mr. Wil LaVeist, soon to be Dr. Wil LaVeist, and always Dr. Keith Newby. Thank you guys so much for joining us today, and we will be right back.
I'm with Marcellus, and you all are checking out Another View on WHRV 89.5. Don't go anywhere. Check us out.
And welcome back. Thank you so much for joining us today. Now, we shared some really important information, and if you'd like to hear it again or share it with a friend, go to your app store and download the brand new WHRO Media app. There you will find podcasts of any other of our Another View shows and all of our programming on WHRV, WHRO, and WHRO TV. We're on Facebook, so like us, and I'm on Twitter at Barbara Ham Lee. Next week, what Virginia Beach Public Schools are doing to ensure equity in education for all of their students. Our theme music was composed and performed by Jay Sennett. Danny Epperson stepped in as producer today while Lisa Godley is away. Victor Bowen is our audio engineer, and Mercedes Sutherland answered our phones. I'm Barbara Ham Lee. Thanks for listening, everyone, and let's get together again next Friday at noon for Another View.